Final presentation is entitled Safety and Efficacy of Intravenous Infusion of Ischemic-Tolerant Allogeneic Mesenchymal Stem Cells in Patients with Non-Ischemic Cardiomyopathy. So two different patient groups from Professor Javed Butler from Atlanta.
Hi, thank you very much for the opportunity to present in this forum. These are my declaration of interest. Very small. So the background of this therapy or this trial is that the direct myocardial injections with mesenchymal stem cells in the previous trials, mostly in patients with ischemic heart failure with low ejection fraction, have been shown to be safe and there are potential efficacy signals. However, the mesenchymal stem cells secrete a broad array of molecules that have potential beneficial effects, including anti-inflammatory effects and immune modulatory activities. Although there are multiple hypotheses of how the stem cells might regenerate the heart or improve the cardiac function, one of the most prevalent theories is that this effect is related to paracrine effect and not necessarily cardiogenesis per se, because these cells are there, if injected into the heart, only transiently. If true that most of the benefit is related to the paracrine activity, then perhaps intravenous therapy by itself could potentially benefit patients as well due to their systemic effect rather than intracardiac injection. And more so, there are data that suggest that ischemia-tolerant bone marrow-derived allogeneic mesenchymal stem cells that are grown under hypoxic conditions have enhanced paracrine properties. So we aimed in this study to assess the safety and preliminary efficacy of ischemia-tolerant mesenchymal stem cells which were given intravenously to patients with non-ischemic cardiomyopathy. The broad eligibility criteria was patients with non-ischemic cardiomyopathy where coronary artery disease has been ruled out, low ejection fraction less than 40%, NYHA class 2 to 3 symptoms. We did MRI on every patient to make sure that the patients don't have hyperenhancement, with the hypothesis being that this paracrine activity perhaps will be more beneficial for patients with dysfunctional but viable myocardium as opposed to those patients that have a large burden of fibrosis. And these patients were stable on medical therapy for at least 3 months. It was a phase 2A single-blind study, placebo-controlled, and at 90 days, the patients were crossed over. So patients who got the cells at the first baseline were at 90 days crossed over to placebo injections, and those that got placebo were crossed over to the cell injection. So in essence, then what happened was that half the patient that received placebo and subsequently received cell also had 3 months data after the cell. So we have half the patients in the placebo arm and double the number of patients in the treatment arm for our analytic purposes. The intervention was ischemia-tolerant MSCs with a single dose of 1.5 million cells that were given per kilogram IV, as opposed to the placebo group that received ringer lactate. We randomized 23 patients. One of the patients prior to injection post-randomization decided not to move forward. So basically, in the first round, 10 patients received injection and 12 received placebo, and at 90 days that were crossed over. So these are our preliminary results. In terms of the clinical outcomes, there were no differences between the two groups. Cell-related AE was only one. That patient had a bruising at the IV site. Rest of the outcomes were pretty comparable. We had baseline 90-day and then 180-day after the crossover as well. Holter monitor result, liver function testing, renal function testing, and we actually performed pulmonary function testing because most of these cells theoretically will lodge and home in the lungs and the liver. And there were no differences seen between the two groups in terms of FVC, FEV1 over FVC, or the diffusion capacity. So there were no safety signal of concern that arose from our study. In terms of the preliminary efficacy signal, there was a statistically significant improvement in patients' exercise capacity. If you look at the mean difference between the two groups, there was about a 36-meter difference at the end of the 90 days between the two groups, which was significant, and so was the percentage difference, which was about 16%. We also found a signal in improvement in quality of life scores, which were assessed with Kansas City Cardiomyopathy Questionnaire. The functional status score was greater than 5.65, with a strong trend towards significance, whereas the clinical summary score did reach statistical significance at 5.2. In terms of the left ventricular function, if you look at the first 10 patients at the baseline who got the cell injection, there was a significant reduction in LV and systolic and end diastolic volume in these patients. However, if you look at the placebo group that at the baseline got placebo, and there was a sizable reduction in the volumes in that group as well that got placebo, though substantially less, almost half that of the mesenchymal stem cell, but nevertheless there was a reduction. But if you do statistics in sort of a more traditional way where you compare the mean differences between the two groups, it was not statistically significant. That was in the first 90 days, and we did this analysis because we did see this trend in the 90 days. But if we do the analysis like we did for all other measures like PFTs or LFTs, where we compared the 22 cells patients with the 12 placebo patient, we did not find any difference, which was likely related to the initial improvement in the first 3 months in the placebo arm. So in summary, single administration of intravenous ischemia-tolerant mesenchymal stem cells in patients with non-ischemic cardiomyopathy, low ejection fraction, was found to be safe by multiple assessments, improved 6-minute walk test, and KCCQ clinical summary score with a strong trend for functional status score. However, there was no significant change in left ventricular function. And future studies are needed to confirm these findings in larger portion of non-ischemic patients, focusing more on clinical endpoints, looking at ischemic cardiomyopathy patient, and also to test whether more than one injection perhaps can lead to a more sustained improvement in cardiac function. Thank you very much.
Thank you. This presentation is open for questions. Mitch? Yep.
Mitchell Zola, Cardiology News. Dr. Butler, could you address how clinically meaningful is a 36-minute average increase in walk and the 5-point increase in the Kansas City questionnaire score?
Yeah, so the Kansas City cardiomyopathy score, overall score, 5-point, has been linked to improvement in hospitalizations rate and mortality rate in other heart failure trials, not in the stem cell trial, but in other heart failure trials. And 36 meters actually for a heart failure population is pretty significant, and it's about the range where other conditions like pulmonary hypertension or peripheral vascular disease has been considered to be a significant and clinically meaningful improvement. So it's about the same range.
Yes?
Oh, hi, Shelley Wood with TCTMD. Dr. Bartonek called this field of research new, but I feel like I've been at cardiology meetings for 15 years now, and I've seen so many studies like this. And can you just, I've stopped covering these, to be honest, but I'm thinking about covering this one, and I just need to know why. If people are going to read my story and cardiologists are going to learn something from this, you know, why is progress so slow in this field? And what are we gaining with all these small studies with soft endpoints?
Yeah, so very, very relevant question. I completely agree with you. So in terms of this, specifically for this trial, I think the novelty here is that we're talking about giving an IV injection, and if in the future this is proven to be of benefit in terms of clinical outcomes for patient, you're potentially looking at giving IV therapy even maybe in the outpatient setting. So that's sort of the novelty as opposed to giving intracardiac injection, which becomes difficult if you're going to give it to millions of patients, or perhaps if you have to give more than once. So that's sort of the attractiveness of the approach. But I cannot agree with you more that the smaller studies, how much do they predict in terms of the long-term outcome, and when will we start doing more phase 3 sort of traditional studies is a question. There are some of them going on, but not as much. These trials are very, very expensive, even the smaller ones. And I think in the absence of doing these small studies first and getting the signal, it becomes a little bit different. And then the last question that you asked, the third part, is that, the reason why 15 years may be still a small time frame for a therapy like this, because there are multiple different kinds of stem cells, multiple different kinds of doses, multiple different kinds of injections and routes that are available, and patient population. To sort all that out, it takes some time.
Well, it's not easy. So just because it's hard doesn't mean we have to. I can understand why you might not want to keep covering it, but I think scientists have to keep chipping away at it. I think it is the Holy Grail. If we could regenerate the heart, that would solve many, many issues. But I think it's very complex, and we've tried to make it look too easy by just taking cells and putting them into the heart. I think we've got a lot more to learn.
But the regenerative principle is literally off the table. I think it's more a paracrine, or what you call a pleiotropic effect, that we may want to speculate about. If we were not so intrigued and would intuitively embrace this idea, we wouldn't have kept it alive for so long and even accepted for a hotline, although it's a relatively small trial. But I think we don't have any conclusive data at the moment.
May I comment? In our case, I would like to add the fact that the study that we have performed now
Can
is a
you
result
move
of
closer to it?
the study we performed is a result of 10-year program where we went over from the basic research data to the phase 2 study up to here. So I think it's somewhere logical that after 10 years you obtain maybe the first, though overall neutral, but first tangible signals. I don't know what the microphone doesn't work. So I think it's something that you have to take along with that. And but I agree with you. What was mistake in the past, it was done in a big rush. In a big rush, where the studies were started without deep thinking, with the over enthusiasm about understanding the simplicity, so-called simplicity of the therapy. It's not like that. It's more complex. And I think we are learning along the way together with advances in basic science. And we are also learning clinical arena. It's neutral what we have found, but we have found very important information. And I think, as Dr. Ruchka is saying, we have to go on because this is something that could potentially...
Joseph, all well taken, but still, you increase the way you deliver the cells, you change the cells. We've all seen that. And yet you have a reasonably substantially sized trial and you have no benefit. So we've heard these arguments all along over the last 10 years. I think we have to also rethink a little bit what we're doing. So I think we have 5 minutes. Thank you so much, Javed, and for some general questions.